Dear Peter, thank you very much for the kind introduction. I suppose it was a kind introduction because I didn't really understand. Distinguished members of the medical faculty, dear colleagues, ladies and gentlemen. Is it on? Can you understand me? Yeah. Yes. It's a great honor and pleasure to be here and to speak in front of this audience about one of my favorite topics, which is how to provide deaf people with the chance to get back into acoustic life, to give them a chance to hear sounds, to maybe listen to music, and the main goal is to give them the chance for verbal communication. Hearing problems are big and large in Central Europe. And if you look to Germany, we have about 15 million people that suffer from a sensory hearing loss. These are not all people that need hearing aids, and only a few which need cochlear implants. But still, these are people which have a measurable impairment of hearing. So this is basically every fifth patient in Germany which has a hearing problem. Most of these patients can be sufficiently provided with conventional hearing aids, and you all know these very well, which need to be adapted somehow to the external auditory canal. If people are not sufficiently provided or unhappy with conventional hearing aids, in the meanwhile, we have a number of options of electronical hearing devices, implantable hearing devices, which can be either adapted at the area of the middle ear, ossicles, or directly to the oval window or to the round window. These are the middle ear implants. If it's mainly a sensory problem and the hearing impairment is too big for hearing aid fitting, we may think about and discuss cochlear implants. This is the topic of tonight. And for a very few number of hearing impaired patients, auditory brainstem implants may be indicated in the case the auditory nerve is affected, for instance, after removal of an acoustic neuroma. So basically, all patients with hearing problems should get some support in the one or the other way. Tonight I would like to address the cochlear implantation, a system which consists of an external audio processor with a microphone that takes up acoustic sounds. These sounds will then be manufactured, so to say, after fitting of the processor, and the altered signal will then be transferred via this antenna area transcutaneously to the implant, and from the implant it goes via an electric wire into the inner ear, into the cochlea. And these are the different electrodes inside the scala tympani, inside the inner ear, and they directly stimulate the hearing nerve fibers, the spiral ganglion cells, which are here in the center of the cochlea. The classical indications for cochlear implants were bilateral severe hearing loss or bilateral deafness. During the last years, new indications have been developed, and over the bilateral severe hearing loss and deafness, we implant today patients with different indications. What do we expect from a cochlear implant today? We would like to be able to treat patients' individual hearing loss. If present, we would like to preserve residual hearing. Electroacoustic stimulation will be addressed during my talk. We also implant patients with a deafness on one ear, single-sided deafness. We want to be able to cope with the individual cochlear anatomy, for instance, in malformation of the temporal bone. And if necessary, we would like to reach a complete cochlear coverage. We want to have flexible and adaptive electrodes for every individual situation, so different length and different flexibility. And we want to be able to insert these electrodes through the round window or through a cochleostomy if necessary. So these are different audiograms from patients which are eligible for a cochlear implant. Look at this patient. He has a normal hearing on the right side and close to deaf ear on the left side. This patient also has a close to deaf ear on the left side. This is a patient with otosclerosis and mixed hearing loss with a conductive part on the right side. And this patient has a normal hearing on the left ear, a good hearing in the low frequencies, and then a slope from 1 kilohertz down to deafness. And all these patients, which are difficult to provide with conventional hearing aids, should be discussed for the one or the other way of cochlear implantation. Another aspect I would like to address is the anatomical variability of the inner ear of the cochlea. These are different cochleas from different patients, and you see that no one is similar to the other. So the cochlea is somehow like a fingerprint for every patient, and therefore we need to have an electrode design to deal with this special situation. This is one of the different available cochlear implants, which has a small and flat titanium housing. And this is the electrode carrier, which has at this point is the area where it goes into the cochlea. And these are the different electrodes, 12 in this case, which go inside the scala tympani. The implants need a magnet to hold the external processor. And as mentioned already, we want to have an electrode choice dependent on the patient's need. Flexible and atraumatic electrodes are necessary to preserve the cochlear structures. Also, in particular, when the patient is deaf, you may think, well, it's not necessary to preserve intracochlear structures, but we believe that also in this patient, it's advisable to make as less damage as possible. And in particular, in those patients who have a remnant hearing, you need to be very gentle inserting the electrode because you want to preserve the low frequency hearing in these patients. This picture shows you the result of a study of measuring the cochlear duct. And what we find is this Gauss curve, which shows that the cochlear duct, or the length of the cochlea, varies between 25 and 36 millimeters. So it's maybe not advisable to take the same electrode length in every patient, but look for the cochlear length and then adapt the size of the electrode. If required, we prefer complete cochlear coverage, so this electrode really goes into the tip of the cochlea where the low frequencies are located and the neural elements can be stimulated in this way. Modern cochlear implants are MRI compatible. They are safe for MRI up to 3.0 Tesla without removing the magnet. And the magnet in this case is movable and self-aligning, and therefore reduces the trauma to the patient, and it's also easier for the patient to stand during his MRI investigation. When we talk about surgery, it's a standard surgery today, but still we have to consider the technical background. And this is a picture from my teacher, Jan Helms from Würzburg, and he taught us to follow the green marked pathway. This is the entrance of the outer ear canal. This is the bony shell of the sigmoid sinus. This is the skull base, middle fossa, border to the middle fossa, incus, horizontal canal, facial nerve. And if you follow this green marked pathway like a pilot with his plane, then you are safe and you come to the promontory area where you find the access to the round window niche and the round window, which is, at least in our department, the main goal to implant the electrode. Our access to the cochlea is a transmastoid posterior tympanotomy approach. Here you see again sigmoid sinus, cause of the facial nerve, incus. This is the image of the cochlea, and this is the posterior tympanotomy or facial chorda recess, which needs to be opened with a drill, preserving the facial nerve, leaving a thin bony cover over the nerve to not injure the nerve, and then exposing the area of the round window niche. This is a little video, surgical video, which I wanted to show you. A left ear, this is the earlobe, post-auricular approach, drilling out the mastoid cells. Horizontal canal, that was the incus, which was touched with the sickle knife. Posterior canal wall, and then the posterior tympanotomy is drilled out with a small diamond drill, exposing the facial nerve, exposing incudostapedial joint, promontory, and down there you can make out the entrance into the round window niche. Talking about the round window, we have to consider anatomical situation at this area. Usually the bone on top of the round window entrance covers the round window membrane, and often we find a mucosal fold in this area, and this of course is not the round window. This needs to be opened surgically, and sometimes we have to drill down the bone here on the bottom of the round window niche to completely expose the actual round window. And I also have a short video for this later on to show you. This is a temporal bone CT, which also shows the cochlea, the scalae, and this is the round window area, and this is the bony covering. And you can imagine when you have your microscopic view in this direction, you cannot directly see the round window. You have to drill away this bone, maybe this bone, and then you can expose the area of interest. This is a temporal bone picture which shows the atraumatic insertion of the electrode carrier through the round window into the scala tympani, and these are the nerve fibers, spiral ganglion. You can imagine that via the electrodes here, the hearing nerve endings may be stimulated, and this information may be transported to the central auditory area. This is another short operation video to show you how we continue. You have a look through the posterior tympanotomy. This is horizontal canal. This is incus. This is promontory. This is pyramidal process and stapedial tendon. And this is the entrance to the round window niche. And now we continue. Sorry. To open the mucosal fort with a little hook, with a little kukichka, I learned. And then we drill away the bony overhanging, and this, what you see here, the gray area, this is the round window. Look at it. You have not often the chance in your life to look to the round window. And then under steroid bathing, the round window is gently opened with a sickle knife or with a peak. This is opening of the scala tympani. And then the flexible electrode is guided in very gently till to the silicone mark on the electrode carrier, like this. And we usually do it in the presence of fluid steroids as a protection for the inner ear. At the end, we seal the entrance at the cochlea with little connective tissue pieces, and this is the situation at the end of surgery. In some patients, the round window may be torquated under the stapedial tendon that you are not able to insert the electrode into the round window. In these cases, you can also choose a cochleostomy, and landmarks are the head of the stapes, and the width of the stapes is then left free, and in this position we drill with a 0.8 or 1.0 millimeter drill into the scala tympani, which looks like this. First we start with a bigger drill and drill till to the periosteum or the endosteum, and then we take a 0.8 drill, and this is the opening of the scala tympani, and also via this access the electrode can be inserted into the cochlea. Our standard approach is the round window access. We prefer this because minimal drilling and minimal trauma is possible in this access, low risk of noise damage, and if you open the round window, you have a safe access to the scala tympani. If the round window is not accessible, we choose the cochleostomy approach. This is a post-operative computer tomography of the temporal bone, and you can nicely see that the electrode goes into the cochlea, and these are the different electrodes. So this is a good positioning of the electrode. Sometimes not easy if there are narrow situations, if there's partial obliteration of the cochlea after infection, for instance after meningitis or after trauma. In these cases, you may also use a dummy to test the scala tympani for the electrode insertion. In bilateral deafness, our concept is bilateral cochlear implantation. From hearing aid fitting, we know that bilateral hearing is crucial for hearing perception in noise and for directional hearing. And also patients report about a more natural hearing if they have the chance to use both ears. So in bilateral deafness, we provide bilateral cochlear implantation, if possible, in one surgery. Simultaneous bilateral implantation we try in congenital deafness, starting about from the first year on. In younger children, it's difficult to do both surgeries in one operation because it takes a certain time, and then you have to discuss with the anesthesiologist or with the pediatrician whether it's possible. Otherwise, we choose a sequential implantation, start with one side, and then after 6 months or 9 months, for instance, we implant the contralateral side. Meningitis and trauma was mentioned already. In particular in children after meningitis, the cochlea may be obliterated even after 4 to 6 weeks. So the ENT doctor should be aware of these children, because when they have the meningitis, it's a life-threatening disease and everybody is concerned about life. But when the kids are better or the patients are doing better, then they sometimes forget about hearing. And this is important for the ENT doctor to be present and perform the hearing tests, and if necessary, suggest these treatments. Because later on, when the cochlea is bony, with a bony obliteration, it may not be possible to place the electrodes. Bimodal stimulation means that one ear is deaf and the contralateral ear has a hearing impairment, but can be still provided with a hearing aid. So in bimodal stimulation, you have a cochlear implant on one side and a hearing aid on the other side. And this is what we always try when the patient tolerates it, because most patients have a benefit from this kind of fitting. Electroacoustic stimulation is a special hybrid fitting of cochlear implants together with conventional hearing aids. So this means cochlear implant and hearing aid for the same ear. For instance, for patients with residual hearing in lower frequencies, they either don't need a hearing aid if they have a normal hearing in the lower frequencies, or if the hearing is impaired at these frequencies, and in the high frequencies there is no hearing at all, no hair cells, no vivid hair cells at all. These patients get a short electrode, like 20 millimeters, which goes into the scala tympani, and you remember the low frequencies are at the base of the cochlea, and in the tip of the cochlea, where the low frequencies are, we want to stimulate hearing with a conventional hearing aid. And nowadays, this hybrid system is available as one technical tool. So you can provide the patient, you can preserve his natural hearing and help him with electrical stimulation at the high frequencies. Goes along, according to the patient's information, with a quite natural hearing, in particular also from the own voice, which is obviously quality of life for these patients. And is an interesting concept which was started in Frankfurt in Germany, to my knowledge, with Professor von Ilberg, and in Germany is now a standard procedure for those patients. There are not too many, of course, but if the patient has the correct hearing audiometry situation, it's a very good choice for the patient. This is how it looks like. This is the audiogram. You see in the low frequencies there's a decent remaining hearing, and then we usually have a slope around 1 kilohertz, goes down till to deafness in this area. So the audiogram should be in between this red area. And this is how it looks like. This is the processor which goes to the hearing aid here, to the external canal, and also, like in the other cochlear implants, to a short electrode in the scala tympani. Electroacoustic stimulation. Cochlear implantation in patients with deafness only on one side and normal hearing on the other side is in discussion for several years. First experiences were reported from Belgium, from Antwerp. They started in patients which had a deaf ear but a severe tinnitus problem. And they implanted these patients and were able to restore hearing, and in about 80% to improve tinnitus, to suppress tinnitus, or to make tinnitus better for the patient. And in the meanwhile, at least in Germany and in other European countries, single-sided deafness is an accepted indication for cochlear implantation to allow the patient's directional hearing, improve hearing in noise, and in those patients who suffer from tinnitus, improve the tinnitus. What are the features of modern cochlear implants? They should allow the surgeon to perform an atraumatic, flexible surgery and insert the electrodes in a way not to damage the inner ear tissue. There should be different electrode variants available for the different indications, like short and long cochlea, malformations, in particular in children, and also special situations if the cochlea is partially obliterated. You may have split electrodes which go in the different scalae, and so you need to have an array of electrodes available intraoperatively to be successful. At the end of surgery, you can measure with telemetry, nerve response telemetry, the answer of the hearing nerve if stimulated over the cochlear implant. And on one hand, you know whether the system works, and on the other hand, you get some information that may be used for the first fitting, in particular in small children. Over the last years, the speech coding strategies were improved almost every other year, and with the present processors, many of the patients can communicate, can speak, can understand speech, can use the telephone, and can also listen to music, to classical music, which is an audiological challenge, but this is possible today in many patients. MRI safety up to 3 Tesla was mentioned already, and all these systems are FDA approved today. What you should know is that cochlear implants are not medical devices like hearing aids, but from the heuristic side, they are like organs. So they are treated like an organ of the patient, and therefore they also need physicians to take care of the patients lifelong. You may cooperate with technicians and acoustics, but the responsibility for the cochlear implant patient stays with the surgeon and the doctor who does the implantation. This is important. The outcome of cochlear implantation is the following. We have to keep in mind that CI cannot completely replace the damaged inner ear. The patient still remains a hearing impaired patient. And this is important, for instance, for children. In Germany, we give them special support in school and when they do their professional training, etc. So you have to keep in mind that this is still a hearing impaired patient, even if he is able to speak and to telephone and so on. More than 90% of our patients have a clear benefit of the cochlear implantation. I would say even more than 95%, and are wearing the cochlear implants all day long. Some even forget to take it off when they go to bed because it's part of them, so to say. In congenital deafness, it allows development of hearing and speech development in small children, and in adults that, for instance, become deaf from hearing loss, it improves speech discrimination even in single-sided deafness. Open communication is the goal of our treatment and needs training, so it's not only the implantation, it's not only the surgery. The main work starts after surgery with the training. And you can imagine that in adults, that suffer from a postlingual deafness, it goes faster. But in children with congenital deafness, it may take months and years for training and continuous support for these children. But many of our children have the chance to go to a regular school and also go for a regular professional development. And we have the first children which were implanted 20 years ago, which now go to medical school. And a few months I saw one of this patient, and this makes the surgeon happy if you see that the circle somehow closes and these children have almost a normal chance to establish themselves in society. So our cochlear implant philosophy extended the classical indication of bilateral complete deafness as showed in my talk. So in general, you can keep in mind a cochlear implant is indicated if sufficient hearing aid fitting is not good enough for the patient anymore. Then you should discuss cochlear implantation. We try to implant children about the age of 1 year, if possible a little earlier, but 1 year is good enough. If the children are more than 3 or 4 years, the chances get worse and worse. So early diagnosis and early implantation is very important. We provide bilateral cochlear implantation for bilateral deafness, also in prelingual deafness and after meningitis. Bimodal fitting was discussed, also electric acoustic stimulation and cochlear implant in single-sided deafness. So as you may see, cochlear implantation needs a very differentiated diagnosis and an interdisciplinary approach with many people, starting with the pediatricians and the surgeons and the acoustics and the logopedics, and if needed, even more people. So you need a team to do cochlear implantation. And it's a long-lasting procedure. For the surgeon who implants, it's a lifelong relationship. But in most cases, it's a very successful and promising relationship. And I'm glad that we had the chance here in Stara Zagora to start a cochlear implant project with Peter Ruev and his team. And we are doing this for a couple of years now, and we want to continue this. And I hope this will be a very successful cooperation for the future. And also for you, I think, an interesting project to follow and to get good treatment for your patients. Thank you very much. And if there are questions, I'm ready for discussion.